In our last class, we followed a blocked artery to dying muscle. Today, we pick up the two tools critical care gives you for the sickest cardiac patients: the numbers that tell you what the pump is doing and the decisions you make when a rhythm turns dangerous. Let us start with the numbers, and let us tie everyone back to the model you already own. Remember the 4 dials from the first week: heart rate, preload, afterload, and contractility. Hemodynamic monitoring exists so you can see those dials instead of guessing at them. A blood pressure cuff gives you a number every so often. An arterial line gives you a waveform continuously, beat by beat, and lets the team draw blood gases without another stick. The number you care about most is the mean arterial pressure, the pressure your organs actually feel. Normal runs about 70 to 100, and 65 is the usual floor for organ perfusion. Central venous pressure, measured through a line sitting near the right atrium, is a rough window on right-sided preload, which in practice means volume status. Normal is about 2 to 6. Low suggests an empty tank. High suggests either too much volume or a right heart that cannot move what it is given. The pulmonary artery catheter threads through the right heart into the pulmonary artery. It is used less than it once was, but you will meet it. Its wedge pressure, normally about 6 to 12, estimates left-sided preload. Through the same catheter, you get cardiac output, normally 4 to 8 liters per minute, and cardiac index, normally 2.5 to 4, which is cardiac output adjusted for body size, and therefore the more honest number when you compare patients. From these, the team calculates systemic vascular resistance, normally 800 to 1200, your window on afterload. Now here is where the numbers stop being trivia and start being diagnosis. Different kinds of shock produce different signatures, and if you learn the pattern, you can often name the problem from the flow sheet. In hypovolemic shock, the tank is empty, so filling pressures are low, cardiac output is low, and the body clamps down, so resistance is high. In cardiogenic shock, the pump has failed, so blood backs up. Filling pressures are high, output is low, and resistance is again high. In distributive shock, the septic picture, the vessels have dilated, so resistance is low, filling pressures are low, and output is often normal or even high. And in obstructive shock, such as cardiac tamponade, something outside the muscle is preventing filling, so pressures rise and equalize while output falls. Low filling pressures with high resistance means give volume. High filling pressures with low output means support the pump. Low resistance means the vessels are the problem. Same 4 dials, 4 different stories. 2 bedside rules before we leave the numbers. First, these lines only tell the truth if the transducer is leveled to the phlebostatic axis, which is the 4th intercostal space at the midpoint of the front to back depth of the chest, not the middle of the chest wall you can see. Level it there, zero it to air, and re-level it every time the patient's position changes. A transducer at the wrong height gives confident wrong numbers, and people treat wrong numbers. Second, look at the patient before you believe the monitor. Now the unstable rhythm. Last week, you learned to ask 3 questions of any rhythm: fast or slow, regular or irregular, and is the patient tolerating it? Today, we answer the last one with actions. And everything starts with one branch point. Check for a pulse. If there is no pulse, you are in cardiac arrest. And the very next question is whether the rhythm is shockable. This distinction matters more than almost anything else you will learn this week. 2 arrest rhythms are shockable: ventricular fibrillation and pulseless ventricular tachycardia. For these, the treatment is high-quality CPR and immediate defibrillation. Defibrillation is an unsynchronized shock delivered as soon as the machine is charged, because in a chaotic rhythm, there is nothing meaningful to synchronize to. The goal is to stun the whole myocardium at once, so the sinus node can take back control. Two arrest rhythms are not shockable: pulseless electrical activity and asystole. In pulseless electrical activity, the monitor shows organized electrical activity, sometimes a rhythm that looks almost normal, but the heart is not generating a pulse. In asystole, there is no electrical activity at all. Shocking these does nothing. There is no organized activity to reorganize. The treatment is high-quality CPR and epinephrine, and then the real work, which is hunting the reversible cause. You will learn these as the H's and T's: hypoxia, hypovolemia, hydrogen ion or acidosis, hypo and hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, and thrombosis in the lung or the heart. In a non-shockable arrest, finding the cause is the treatment. So do not take away no pulse means shock. Take away no pulse, then check whether the rhythm is shockable. If there is a pulse, but the patient is unstable, meaning hypotensive, confused, having chest pain, or showing signs of shock, and the rhythm is dangerously fast, the treatment is synchronized cardioversion. The word synchronized is the whole point. The machine times the shock to the R wave and deliberately avoids the T wave because a shock landing during repolarization can throw the patient into ventricular fibrillation. Pulse present, we synchronize. Pulseless, we do not. If the rate is too slow and the patient is symptomatic, atropine is first. And when atropine fails, or when the block sits low in the conduction system, transcutaneous pacing takes over. Pacing is painful, so an awake patient needs sedation and an honest explanation. And always confirm that the pacer is capturing, meaning every spike produces a real QRS. Then confirm it mechanically by feeling a pulse. Electrical capture without a pulse is not perfusion. If the rhythm is fast, but the patient is stable, you have time, and time means drugs rather than electricity. For a regular narrow complex tachycardia, you start with vagal maneuvers, then adenosine, given as a rapid push with an immediate flush because it disappears from the blood within seconds. Warn the patient that a brief pause and a very unpleasant feeling are expected. For ventricular rhythms in a stable patient, amiodarone is common, with one crucial exception. If the ventricular tachycardia is polymorphic, the twisting pattern called torsades de pointe, amiodarone is the wrong drug because it prolongs the QT interval further. Torsades is treated with magnesium and by correcting the potassium and magnesium that usually caused it. Keep that exception close this week. You will meet it again in your case study. So, take 3 things into our next class. Every monitored number maps to one of the 4 dials, and the pattern across those numbers names the type of shock. In any arrest, the question after no pulse is this shockable? Because 2 rhythms are, and 2 are not. And with a pulse, stability decides urgency. When we meet, we will read real hemodynamic profiles and work through rhythms where you decide out loud what happens next. See you in class.